lunch, so we'll try to make sure that we keep our time, which is 50 minutes. So thank you very much for the opportunity. I recently moved from Chennai to Bangalore, so very happy to come back to Madurai. So I would like to invite all the panelists. First, I would like to invite Professor Ramani Rajendran, former professor and chief of Department of Obstetrics and Gynaecology, Institute of IOG and KG Hospital. Welcome, ma'am. So, ma'am, as you know, has been associated with the cancer control program ever since the cancer control program started in the state, and she doesn't need an introduction. Please, ma'am. Ma'am, you can go there. Yeah. Next, I would like to invite Mr. Ranjan Kumar Jha, Senior National Program Officer, Food Fortification, Nutrition and International. May I request you to come? Next, I would like to invite Aarushi Bhatnagar. I think everybody knows her well. She's a senior economist, and she's been supporting the Tamil Nadu Health Reform Project for the past couple of years. Yeah. Welcome, Aarushi. Aarushi, can you move to that side? Yeah. Next, I would like to invite Dr. Krishnaraj, Joint Director, NCD, DPH.
Let's give the
and
panelists
finally,
a warm
Dr.
welcome.
Jerard, Additional Director, NHL. Again, we have been together in the NCD world for ever since NCD program started, I guess, in Tamil Nadu. So, welcome all. So, as you all know, next slide, there is the slide check. Not working. You want to change it there? You want to change it from there? Next. I think this. So, I think we don't need to sort of sell that NCDs are a problem, but just to set the stage, we know that of the 5 leading causes of death and disability in India, 3 are NCDs, which is cardiovascular disease, chronic respiratory disease, and neoplasms. And we also know that nearly every 4th death is due to cardiovascular disease, especially in most states in India and especially in Tamil Nadu. Next slide. So today's panel will be will be reflecting on these goals. So these are the global goals that all the countries have agreed on, and India is also signatory to that. So these are 9 voluntary global NCD targets which we are expected to achieve by 2025. Of course, we are not achieving by 25, but can we achieve them in 2030, 2035 or whenever possible? But we should at least know, are we going in the right direction? So I think our panel today will be very futuristic. So we have decided not to so much spend time on what's already been done, but to be futuristic and see how we meet these goals. And as you can see here, the blue is the goals which are linked to risk factors. So we should remember that we are constantly talking about, disease-centric care. But actually, to achieve the NCD goals, we need to work on all these risk factors: salt, tobacco, physical activity, harmful alcohol use, raised blood pressure, and salt. And the 2 which you see in pink here are the health system-centric goals. And finally, what we want to eventually achieve is the premature mortality reduction by 25%. What do you mean by premature mortality is people dying of NCD between the age of 18 to 69 years. Next slide. And just to set the stage for Tamil Nadu, this was a STEP survey that you all know. We had a dissemination a couple of months ago, and all the risk factor, the prevalence is quite high, and hence need for this panel. So we will move on, and we will be going through many of these risk factors and looking at what should be our strategies going forward and listening from all our experts. Next slide. So first I may request Professor Ramani to share her thoughts on what she thinks is the current status and way forward for the cancer programs in the state of Tamil.
Good afternoon to all of you. Very good afternoon to all of you. At the outset, I would like to thank the DPH and his entire team for giving me this opportunity and for their hospitality. Coming to cancer cervix, as all of you are aware, it is a preventable and easily curable disease provided it is diagnosed early. But the sad part is people come to us very late. And in 2020, the WHO has started this initiative where about, I think around 195 to 200 countries are enrolled in this mission to reduce the incidence of cancer to 4 per lakh by 2030. We are already the end of 23. We have only got 6 more years to achieve this goal. For that, they have devised a formula known as 90-70-70. Please stand. Right. 90% of the girls should be fully vaccinated by HPV vaccine before the age of 15, before their 15th birthday, which means they only will require 2 doses. And 70% of women should be screened by at least twice in the lifetime, 35 and 45, by a high effective method. And 90% of women who have been detected with precancer lesions should be adequately treated. And those detected with cervical cancer have to be referred to the tertiary or district cancer hospitals. So the easiest way to remember, the previous speaker has mentioned so much about GST, is the easiest way is whenever you see a bill, right, you should always remember 90% of the girls, 70% of the women, and treatment should be about 90% of all this. So GST is the best way to remember this. This is the tax levied on all of us. It is our commitment to achieve this goal. Next slide. Coming to the secondary prevention, our own society, the Forti and the ICOG and the WHO, next, recommends screen and treat. 2 policies. And screen, triage and treat. In screen and treat, you just have a primary test. Ideally recommended is the HPV DNA testing, but what is right now available is, accepted method is the visual inspection of cervix with 5% acetic acid. And with that, if you find a lesion, with that you can, if it fits into the criteria for ablative therapy, at a single go you can finish it. You can treat the patient as well. In the other option, that is screen, triage and treat, you'll have to see a patient with a positive primary test. You'll either have to do colposcopy or a colposcopy and a directed biopsy and then treat the patient. Next. So this map, you see, Tamil Nadu is a part. Right? This goes to the entire team of DPH NHM for having occupied but only Tamil Nadu state has, because we have started the visual inspection of cervix as early as 2005 in the state. Next. So the next step of screening, we have to scale it to HPV DNA testing. Sir, I think you have to take this up, and only screening, diagnosis and treatment, if they are all linked together in the same center, only then it is possible for the success of this program. Next. So the ideal, why they are suggesting HPV DNA testing is, it's objective, high sensitivity and 100% negative predictive value. So that is the best compared to all other methods as of now. So it is time that we take up to HPV DNA testing, and there are different types that has to be done, but initially to start off, we can just do a triage, HPV high risk, whether they are present or absent. Then we can go on to partial genotyping and complete genotyping as well. Next. Coming to breast cancer, this is the saddest part. Even in 2005, when I started, cervical cancer was very high. Breast cancer was slow, very low. But now it is just the opposite. The breast cancer is skyrocketing. Next slide. It's, as of now, in the southern states, Hyderabad has got the highest incidence of, I think, 48 per lakh. Whereas Tamil Nadu, it is around 40 per lakh. So the best thing that we can do about this is the breast examination, which was essential part of NCD in the beginning, has never picked up. Probably there are two things that needs to be prioritized. One is privacy, strict privacy. Second is you need a medical officer, female medical officer, whenever the patient comes. There is no question. So I think you need a separate NCD team for this. Only then it is possible to continue. If you use the general gynecologist, they will be having family planning theatre, they will be having a labor ward duty and post duty off. So unless we have a focused NCD team, including a lady medical officer, I think only then this self-breast examination will gain importance. And second thing is the clinical breast examination, which can be done once a year, so that even a small size or a patani size, pea size lesion can be noted. And the third is the mammogram, which can be offered only to patients beyond 40 years of age. Or if the clinician decides to have that or orders a mammogram, depending on the risk factors in that family. So coming to cancer breast, I think we need to improve more on self-examination, which has to be taught to the young girls. So it is not only the immunization part where you include the school health. We'll have to include the college girls because you have the catch-up vaccination up to the age of 26. So college, educating the girls when they are young about self-breast examination, which should start at the age of 20 years, lifelong. And then vaccination in this group is also, it's a gray zone. And second is about the two things, about nutrition and obesity. This has to be started, inculcated into their mind early. See, once they become obese, dresses don't fit, then they come to exercise. It's a costly affair. So start it, it has to be brought in. Thank you, madam.
Thank you so much, ma'am. Very comprehensive, very quick. So I think there are a lot of takeaway points for the department to think through and the newer strategy. So next we will move on to Mr. Ranjan Kumar Jha, who will share with us the importance of dietary sodium-based strategies. And this is actually connected to what we just heard about taxes. So, you know, we need policy interventions. We cannot just keep on doing individual patient-based interventions. And I think there is a linkage there. So we would hear from Jha. Yeah,
thank you.
Over to you.
Yeah, respected co-panelists and audience, a warm good afternoon from Nutrition International. When we are talking about the sodium reduction, we also need to understand that it's salt, and salt also provides iodine. So when we are talking about, can we have the last slide? When we talk about NCD through sodium reduction, we need to also in the same breath speak about harmonizing it with consumption of iodized salt so that iodine nutrition is ensured. So when we talk about high sodium consumption, it's more than 2 grams per person per day that contributes to high blood pressure, and that increases the risk of heart disease and stroke. And in terms of the impact, it's accounting more than 1.8 million deaths and 45 million dialysis. So when we talk about the dietary sodium and iodine nutrition, both plays a very critical role in the body functioning. And Universal Salt Iodization Program is a globally accepted public health success story wherein iodine nutrition is provided to all the segment of the population. So there is a common thread between dietary sodium intake and iodine nutrition where it's salt. And when we talk about salt, iodized salt is one of the primary source of iodine in our daily diet. And when we talk about sodium, then it's 40% of salt. So if we consume 1 gram of salt, that means we are consuming around 400 mg of sodium. When we look into data, the National Non-Communicable Disease Monitoring Survey indicates that on an average, we are consuming around 3.2 grams per person per day of sodium, which translates to equal of around 8 grams of salt, which is way higher than what WHO recommends at 2 grams per person per day. And when we look into what are the contributory factors, it can be divided into two parts. One can be the discretionary salt, or salt which we put in our household food, or it's consumed through a table salt. The non-discretionary salt, which is more about salt that we are getting from outside our house, that is meal that is prepared outside the house, or processed food, also natural sodium that is present in the dairy products, meat, shellfish, and also in food additives. Can we move to the next slide? So when we talk about enabling environment, which are the policy guidelines or regulation that provides that input in terms of sodium reduction and iodine nutrition? Then the first one is WHO guidelines, which talks about the sodium intake for adult and children, and it says that for an adult person, it should be 2 grams per person per day, and when it comes to children, it should be less than 2 grams, which needs to be downward adjusted as per the energy requirement. Then we have WHO global rating, which rates countries in terms of their performance on salt reduction. And third, we have our WHO guidelines, which harmonizes universal salt iodization with salt reduction. That's at the WHO level. At a national level, we have the NMAP for prevention and control of non-communicable disease, which provides the overarching framework in terms of salt reduction. NIN guidelines in terms of dietary guidelines for Indians, that provides us in terms of what is the adequate quantity of salt that we need to consume, the iodine part, as well as it provides us with guidelines on a healthy plate or a healthy diet. Then we have regulations. We have regulations in terms of packaging and labeling guidelines, which says what needs to be written as a dietary fact on a pouch or a packet, and what should be or how we need to communicate to the external population in terms of any of the food products. Then we have the low sodium salt, wherein sodium is replaced by potassium, which is again something that is coming up. And the last is the toolkit that we have, which is through the Eat Right campaign that was run by FSSAI, which also talks about consuming less of salt. So under the basic passage that it's thoda kam, aaj se thoda kam. So that's a tagline that was there for Eat Right mealers. Can we move to the next one? Okay, so when we talk about the target, it's reducing the sodium intake by 30% by 2025. And in terms of the key strategies, one is that the salt iodization and salt reduction, both are cost-effective strategies, and that should go hand in hand rather than one being an adversary to the other one. Second, when we talk about the discretionary salt, there has to be a long-term sustained campaign to educate population in terms of reducing the salt content in their food. In terms of consumer education, again, we have information that is there in the front of pack labeling on the sodium as well as iodine, so that can be used for education of the consumer. Also, with the food industry, we need to work with them in terms of reformulation of the food so that there is lower salt in each of the food articles that they prepare. Also, there needs to be a nudge for the industry as well as for the population, and hence a conducive policy and legislative guidelines is required. And lastly, in terms of the National Non-Communicable Disease Monitoring Survey, it already has sodium intake as one of the indicators. If that can be extended to iodine nutrition, then it would give the policymakers a lot of information in terms of how to adjust the standards of iodized salt so that the iodine nutrition is also ensured. Thank you. That's from my side.
Thank you very much. I think this was very crisp. And again, I wanted to also, mention that we need to have practical ways of educating people, because we don't know how many grams of salt we eat actually. So one of the things, we were trying some of the strategies in counseling, and we learned if you ask a family, like, okay, for a month, if you're a family of 4, how many packets of salt you actually buy? And then try to see whether divided by 4 how much, and then you see, okay, you reduce. So if you are, let's say, using 1 kg of salt in a month, can you use it in 6 weeks? And then can you use it in 8 weeks? So I think we should also think of practical ways of educating, so that because people can't otherwise really think through how much salt they are taking, right? So we will move on to the next speaker now, to Aarushi. She will share with us insights on, so we have talked about importance of primary care and the nutrition, but we need to have behavior change because we cannot achieve NCD goals without that. And Aarushi will share insights from the recent study which was taken up under the TNHSRP. Over to you, Aarushi.
Thank you so much, and thank you for this opportunity. Very happy to be here again, and very glad to see that TPH Icon is becoming an annual thing, and I hope you continue this tradition. So I think everyone has been talking about changes that are required for combating non-communicable diseases. Some of these are at the policy level, some of these are at the service delivery level. I wanted to speak very briefly about what can we do at the behavioral level, as individuals, as communities, and then as a broader society that we're all a part of. At the outset, I also want to sort of put this disclaimer out there because it's often conceived that behavior change is not the health system's responsibility. It's not the responsibility of policymakers, planners, doctors, other health providers. It's really the responsibility of individuals. They should know better, or they should understand these, understand how to manage some risk factors or prevent risk factors. So I wanted to change that narrative here and say it fairly provocatively that that is wrong. I think it is as much the responsibility of each and every one of us in working for the improvement of a health system that prevention, behavior change are as much our responsibilities as they are those of individuals for whom this could be a real health concern in the future. In that regard, I wanted to talk a little bit about social and behavior change communication strategies. These are called, I mean, there are different names for this term of SBCC, but essentially the idea is for targeted interventions that help people change behaviors. Behaviors not just when they have the disease or the illness that has been diagnosed so that they take better care of themselves, but also behaviors that prevent them from getting that illness altogether. So I think today the health system in Tamil Nadu is advanced enough where if somebody is unfortunately ill, they will get good care, both on the medication side of it, but also on counseling for lifestyle changes, etc. But I think we need to have a view of the future, right? We want those who are currently in their early years of life don't get these illnesses at all. You know, whether it's women, preventing them from getting cervical or breast cancer, or even men. I think sometimes we forget men's health as an important category as well. This is also a group that tends to fall it's the group that tends to have the highest prevalence of non-communicable diseases in their later years, tends to be the group that has the highest prevalence of alcohol and tobacco consumption in most settings, including in Tamil Nadu. So I think these are important risk factors that we need to prevent at the beginning itself. And for this, there is now a growing burden, there is a growing body of evidence that communication or behavior change communication strategies can be used. These are, of course, in multiple settings have been used for RM and CH outcomes very effectively. They have also been found cost effective. It's fairly cheap to develop and implement such strategies. And actually one of the learnings from previous experience is that it's not just one strategy. It's not just one poster. It's not just one video message. It is possibly a package of these interventions that can help to actually make a change. There is now also a growing body of literature that is supporting that the same set of interventions, of course done differently, could also could show a positive effect for combating prevention as well as better management of chronic conditions related to non-communicable diseases. Next slide, please. This is just a model to say that SBCC or behavior change communication strategies need to be targeted at all levels. It's not just about that one individual. It's possibly about that one individual plus their immediate ecosystem of their families. So interventions like asking the families to think through the salt intake, the sugar intake, or other forms of dietary changes that a family itself can think about. It's also about the community that we live within. What can be done at the community level? There are structural issues. Can the community provide safe spaces for physical exercise? Can the community provide behavior change patterns related to diet? You know, all our community activities, whether these are weddings or festivals, how much sugar and salt intake goes into that. So as a community, if you take a stand on some of these things, perhaps that's a stronger motivation for individuals as well to try and change certain behaviors. And then of course there is a broader enabling environment that's a combination of what can be done at the policy level, what can be done at a programmatic level, and so on. But having said all of that, I think it's still important to know that information, unfortunately, is not enough. There's a lot that needs to happen to motivate us as individuals. I think all of us here perhaps know the basics of what we should eat, shouldn't eat, what we should exercise, I mean how much we should exercise, etc. But there is still an innate disposition that doesn't let us do it as much as we should do it, right? So I think understanding those barriers and enablers for that disposition is also really important. And I think for just that, messaging is not alone. So IEC is what usually is our solution. I think that is not enough for us to try and change the behaviors, to try and change those motivating, enabling factors for us. Next slide, please. So just to say that I think a good high quality SBCC strategy requires certain principles. It needs to be evidence-based. It needs to come out of formative research that's done in the setting for which it's designed. It needs to identify, like I was mentioning, enabling factors as well as deterrents to motivation, not just information or exposure gaps. It needs to be people-centric. It needs to also be designed with communities, knowing what are some of their perceived barriers, the stigma, other challenges that they face, so that it's not simply something that's designed from a systems lens about the ease of delivering that communication strategy, because that tends to be, and as you know, as it comes naturally to us as health systems managers to do it quickly. I just want to say that Tamil Nadu is actually in the process of putting together a SBCC strategy, thanks to all of you here. We've done some formative research which provided some very targeted interventions that now the government of Tamil Nadu is in the process of implementing. So hopefully by next time when you have this conference, we may actually have lessons from the experience of implementing the SBCC strategy, at least in a pilot phase. But I'll stop here.
Thank you, Aarushi. That was very comprehensive. Thank you very much. Now over to Krishnaraj sir. Sir, would you like to share what is the vision from the DPH perspective as to how we can reach those SDGs? And what do you think are the strategies which are working, or what do you think we should be doing differently to make it work?
So thank you to all. This is time to panel discussion. For NCD, all are in hypoglycemic. So like that, so many struggles and gaps in our Tamil Nadu like this time. We are captured that blue color in our map in Tamil Nadu. Even though so many financially, so many gaps. So next, these are the few points in few seconds. So improvement and treatment of complications and by follow-up and monitoring. The MTM portal, you know, MTM portal is the portal for handling information, getting and analyzing and based upon acting through the MTM portal initially, right? So this on the way. We are waiting to still improvement needed in the MTM portal. And screening of complications to be need. Always our DPH discussing about every Monday and Friday. We are discussing to start for the complications. Screening of complication is must. We are planning from coming weeks. So yearly detection and management is the base. We are already over 20 to 30% we are done. So, but through the community-based survey, right, and motivating to further treatments. Then integrating private sectors is a challenge till the time the credential for starting gap from the credential sharing from the inter-department to the private. Now inter-department is short outed, but private is the challenge. Till yesterday we are not able to provide the credential to the important private sectors is a very, very challenge, right? Then strengthening the mental health care service is a base because of behavior based upon our mental health. So mental health program in primary level is very, very needed. Only at a block level, even though block level, we are not able to maintain the line list and all things, and the distribution of drug system to be strengthened, right? We should strengthen of mental health care till HSC level, right? In future through the MTM, we are planning. Then the COPD is a data is not available, even though in Tamil Nadu. COPD is a very, very challengeable one, right? Respiratory system and database in emergency data, and is a very gap in Tamil Nadu. Primary, secondary and tertiary care level is now we are handling through the online mode. Now we are quitting from the offline mode to online mode. Slowly we are getting integrated well. But our initiative is so many initiative in Tamil Nadu. So community based MTM, MTM is the model in Tamil Nadu throughout all states. We are collecting more than 1 crores line listing in the MTM portal. Based upon the line list, we are acting. So community based the same, but our challenge is the HR. HR is the main challenge. WHV is one WHV is screening 5,000 population, some places 20,000 population, but ASA based screening may be need. So because of very difficult to one person is visited and covering all things in a particular time. Organized community based cancer, workplace intervention already we are planned. We are shortly we are planning to implementing and inaugurating shortly throughout Tamil Nadu, because of it will help to gap the missed out screening persons. And emergency cardiac loading dose also is innovative things. Always our minister is very interested in things, but one person saved from this initiative is our achievement, right? So pain and palliative care system, even though no manpower, no sanctioning, no policy, even though diverting people, the staff nurse from the extra duties, staff nurse also so many gaps in we will sort it out. Even though we are achieved, we will done so many hearts, right? 8-kilometer walk is an initiative by our CM and DPH sir. We are always always only CM and DPH, some persons are walking 8 kilometers daily based upon their experience. We are also all public health personnel, we are most chance for at least monthly once or 15 days once. We are walking 8 kilometers. It's a very good thing, and SPVCC strategies, RC madam is clearly point out that we are piloted, we are doing the Kanjipuram, right? So these things,
so much to
yes,
the point, and thank you so much. And finally, over to Dr. Jerard Selvam. Sir, would you like to share, because you have been associated with the NCD program for the longest time. So I think leaving aside what has been done, so if you can do a reflection on the way forward as to where we should be going. Yes.
So, good afternoon, everybody. At the outset, I thank our Director of Public Health and the entire team for organizing this very well. I'm standing between lunch and all of you, but still I'm sorry about the situation. Yet, I got only 3 slides, and I'll try to convey things which comes out of the overall observations of NCD program over a decade. Actually, it's a decade. I can tell you the experience we have had in Tamil Nadu with the NCD. Next slide. So, I think I can even stand because, yeah, it's okay. Okay. Now we have a challenge. By 2030, we should achieve our sustainable development goal. It is time for all of us to take the first question. Where are we now? What should we be doing? What is our thinking on this? Second, what do other countries in the world do? When they look at the SDG goals, where do they stand? Is there any lesson we should learn for ourselves, for India and for our own state? What does the analysis tell us? What are the common lessons every country is learning out of it? These are the questions which came to my mind when I prepared this slide. First is, across the countries in the world, common NCDs continue to be a real problem. So your ischemic heart disease still remains a very important reason for premature death in more than half of the countries in the world. And it also has its own share for women and men. So we should also look at this data for our country and for our state. What is this ischemic heart disease? What we are doing STEMI and all that? What we are not. Cancers are a problem all the countries. So we should prioritize for us which are the cancers we should take up. We have taken up certain cancers. Is there any cancer left out? That's the question we have to think about. What does the pathway analysis? This is what now the SDG teams across the world tell us. You should look at your own pathway. What is your own system? Where the pathway goes well, where the pathway doesn't go well. Then the last is, no country could actually reach the target. It is not a very good, it's not a happy note, but I'm saying we all have the year and the targets, but none of the countries in the world are really able to reach it. So we have a lesson to learn from that too. Next slide. What is that we should focus? Achieving the target requires improvement in decline in top priority causes. I think Tamil Nadu that way has started on a right note from the beginning itself, that we should prioritize the disease burden, take up the important diseases and should target it. And we have done it. So that is what the lesson is. Tobacco, alcohol, Aarushi also told very nicely, it will remain for entire world as the biggest challenge for NCDs. And we have to focus on the interventions. Our health system interventions, hypertension, diabetes, we know. Let us see in the next point what we should do further. Primary and secondary cardiovascular disease prevention in the high-risk individuals. COPD, Dr. Krishnaraj mentioned, COPD is also an important NCD program, but it is not given the weightage, it is not given the due importance and respect right now in the national level, in the state level. Everybody recognizes it is a problem, but there are a lot of issues, lot of out-of-pocket expenditure incurred by people who suffer from the chronic lung diseases. Then, acute cardiovascular diseases, the catastrophes, diabetes complication, diabetes food, asthma and chronic obstructive, I already mentioned, and effective cancer screening and treatment. Here I would like to tell you, we cervical cancer screening, breast cancer screening, program nadathurom. This is all administrators mindly irukom. The important lesson we have to learn is the quality of screening, the output you really get. That we will forget over a period of time when we keep doing a routine screening for a thing. So you need a different combination of approaches to achieve your SDG. Next slide. So I have put in this one slide all the points which is very important for all of us. Now, I look into the gaps and challenges for Tamil Nadu. Prevention. We should truly move towards multi-sector. Now, if you want to have NCD control, it should be multi-sector. Certain sectors we have involved, like your Women Development Corporation we involved, school health we involved. But then we have to go a long way. So multi-sector approach, Tamil Nadu should really work out in a true sense. Next is Food Safety Department works under the Directorate of Public Health, but the Food Safety Department, what they find, the harmful practices, the unhealthy practices, how we translate that for the people's benefit. Both, it could be a packaged food or it could be a food available in the canteens and the hotels. So that is another area. HPV vaccination, people have been calling for, people have been crying from the rooftop, and HPV vaccination still not seeing the girls getting vaccinated in our own state. But the talk is going on for nearly 5 to 7 years, if I'm not mistaken. So these are the priority areas. And do we really fully protect our health workers with hepatitis B vaccination? These are all low-hanging fruits I'm talking about. HPV vaccination is a low-hanging fruit. Hepatitis B vaccination. So these are the things, and the vulnerable groups. The vulnerable groups and the workplace setting, people in the workplace setting, occupational health. These are our priority areas in both for prevention and for intervention. Now, disease prioritization. The challenges and system requirements which are to be met out in achieving and monitoring disease control. Hypertension screening control, diabetes screening, now every officer, every medical officer, every public health administrator should only aim for என்னுடைய populationல what is the disease control I'm achieving, hypertension, diabetes. Am I preventing complications? Do I sense the complication well in time? If I sense the complication, what is the mechanism I follow in my health system to capture that complication and prevent deaths? These are the things, lessons, the ringing tone is very important for us in Tamil Nadu. So food clinic, Tanjore model, I went and saw last month. Beautiful model. Food clinic itself is a science by itself. Food clinic establishment itself is a great establishment for the benefit of people. We have to focus a lot on food clinic, vascular complications, and what is the healthcare financing? We have a corporate type of healthcare financing, CMCHS, whatever model we have. Is it still the same we need? Is there a change, revision we need? Or really people still spending more and more hoops, out-of-pocket expenditure? What is that healthcare financing helping out? And with a huge health budget Tamil Nadu is spending, with certain portion only for the insurance spent, are we making a real good benefit out of it? Can we revisit it and see? These are the questions for entire all of us, the entire forum to think more and more. And catastrophes I already mentioned. So I said COPD, long-term care plan, chronic lung diseases, cancer screening management, upscaling community-based screening, which we are doing in the 4 districts now. Colorectal cancer is going to come up as a big problem, so we should prioritize that. Now the last one I'm saying, everybody now recognizes, they say, yes, I agree climate change. If you tell somebody One Health, they say, yes, I understand, I appreciate it. But it is recognized, but it is not owned at all. And we know the disasters happening. We know the consequences of disasters happening around us. You know, every year, knocks at our door telling us the implications. But the point is, we have to own this climate change in One Health for the benefit of everybody. So all these things, prevention, disease management, and all these things, everything, we should look at the gaps for Tamil Nadu and then try to see all the things which are not fitting in properly. We must work together to achieve better gains out of it. Thank you.
Thank you, sir. That was really, really crisp and summarizing everything. I just wanted to have a quick question and any panelist can respond. I think we briefly talked about private sector. I think Krishnaraj sir mentioned we really need to think about private sector participation. I think that is something elephant in the room situation. Especially we know that from our last Dept survey, more than 50% people are going to private sector. We cannot achieve any of our goals if we don't target them. So any thoughts on, could there be a model like under insurance where you have a fixed compensation? You would like to pilot any such models, because such models have been tried in other countries where you have a package that, you know, for whole year's care, private doctor, if they enroll a patient with diabetes or hypertension, they are given certain compensation which could include giving a drug box or some consultation, 1 or 2 consultations in a year. So any thoughts on that from any panelist? Because I think Tamil Nadu now should go beyond, like you already have done a lot in the primary health care. There's a lot has been done, but there are people who are not coming to us despite all those efforts.
I would like to answer this on one point. See, like Tamil Nadu has got a very robust public health system and also health system.
Yeah.
So it is overwhelming. It is so overwhelming. We have such a strong presence. Naturally, when something is very powerfully present, we don't deal much with the other sector, the private.
Yeah, but
So that's one. You take the contrast with UP and other North Indian states where they're going after the private because they don't have the presence of the public health system strong there. There they are engaging actively there, the private sector. So there's a contrast within the country between our own Tamil Nadu versus the other in handling the private. But I do agree with you. We tell about private engagement, but we have not actively engaged them in many areas. It is an area which will also help for Tamil Nadu to do better because everyone needs their space. We can't say I don't need you or you can't say you don't need me. So we need space. Each of us needs space. But because we are overwhelmingly present with a good system, I think we don't give much thought to it. Is my personal opinion. I may be right or wrong.
Any other panelists have a view on this? Because you have to remember 50% of Tamil Nadu is urbanized and relatively less utilization of primary care. Pardon? Yeah, I think Sir will tell us. Any other panelists want to comment?
I can come in
Aarushi?
for a minute. Yes, thank you. I agree with you completely, and I think Tamil Nadu is a state that can experiment engaging the private sector in a creative, innovative manner that hasn't happened in other parts of the country, but has happened in other middle income countries. Whether these are changing the provider payment mechanisms, especially for outpatient visits, because you do see a lot of non-communicable disease related outpatient visits, which are currently not a part of the CMC-HIS or other health insurance systems because they only target inpatient care. So I think there are models out there that one can learn from, which have happened in other countries. I think the second thing, and I know that it's a part of our discussions on the SBCC strategy, is to look at workplace interventions as well. And here, I think the easier one is the formal sector, but the more challenging one is the informal sector workplace engagements. But again, I think these are strategies that can be tried out in pilot forms to learn from before we think of how they can be financed and scaled up further.
Sure.
Thank you.
So we can take one or two questions from audience. I know we are close to lunch, but one or two questions we can take. I think I want to first of all thank all the panelists. They've been extremely disciplined with the 3 slides. I was constantly nudging them on the WhatsApp, and I really thank them for being very disciplined. So we can take one or two questions. Any questions from the audience?
Just one question, ma'am.
You are the only one asking question. It will be nice if others also ask. No, you can ask, but also let others ask.
Fine.
Yeah. Okay.
Fine.
Please go
The
ahead.
place of mental health in NCD and the work pressure that we have got in our own environment is not being addressed.
I think DPH sir can answer that.
It's yet to be discussed and addressed.
Yes.
I request some insight.
Anybody want to respond? I would prefer outside department people can respond to this.
Yes, Friday review meeting included.
Because
Especially
the department answer may be biased, right?
Actually, what he said is very true. We don't practice what we preach because we get an immunity. We work in the health system and we are doctors. We know about everything. So our own stress is nothing much to mind. It's an inherent attitude we develop, but that is not an excuse.
Yeah, but I think I want to respond to you. You asked a very important question. I think we are not putting wellness as part of our workplace strategy itself. Like there should be a wellness no matter where you work. And if we don't learn to do it for our own organizations, we'll not be able to teach it. So I request DPH sir, as an outsider, that he should start a wellness strategy for the staff, which should include maybe a lot of focus on physical activity.
We have created one gym. It was used only for a week. The still room is a waste. We have created a shuttle court. Except 4 officers, no one is coming there.
So I think districts can do that. Maybe easier to do it at district level, in
including
fact.
Jerard who is talking.
So just giving my own experience on that. So, you know, I use this fitness band and my team at NIE, I told everyone that most of them, 10 to 15 years younger than me, had less step count than me. So we sort of decided that everyone will use a fitness band, and then we share with each other in our review meetings, not just the, the technical part, but also what's your step count. And now people have started competing, so maybe you should do that. So I think there are small things we can do to really help out. But I want to also talk about, you said mental health, and I have learned over time that it's really important that we provide what we call as a psychologically safe spaces where people can share their problems and discuss and try to find solutions. Can we take one more question?
Yeah, it was a nice panel discussion that we were able to hear. Thank you all the panelists and the director for providing us the opportunity. And to take on a point which was last discussed, I just wanted to say this conference itself is acting as a stress reliever and mental stress buster.
Excellent. Give a big hand to DPH.
And also increased our physical activity levels over the past 2 days. If you could see the energy levels in the hall yesterday evening.
Thank you. Great. Very good.
Thank you, sir, for giving us this opportunity and the entire team.
Fantastic.
I just wanted to add, because Dr. Ranjan Jha was discussed about salt intake. I think there's a point where we could learn something from our tobacco control. Right. In the sense, initially it was very difficult to control the advertisements on tobacco. I know how the industry resisted it. When I was in schools, I could see ITC advertisements during cricket matches, but nowadays it is not there. But it is being replaced by our star Dhoni and Amitabh Bachchan asking us to consume a packet of Lays packets, 1 kg Lays packet, 30 rupees. And it's being offered during this festival time. I think we should start thinking about primordial prevention among our youngsters by cutting their exposure to these advertisements, at least in prime times. Perfect. Or at least in this. I think somewhere we should start this discussion and we should take it forward. We'll be able to do it. Excellent. From the success of the tobacco control. Thank you.
So banning the advertising to children of, the food, unhealthy food, in fact, is one of the indicator if you go to the WHO framework. So I don't know if it is feasible to do that at least in local language channels, because of course for the English and Hindi it may require national level.
Thanks, Pradap. Madam, please, based upon the Pradap recommendation, this panel may be recommended to our DPH 6 months only. We should maybe conduct the
But the organizing committee may need a wellness program after this. Okay, so one more question last? Okay, sure.
Okay, thank you. Actually, it's not the question. It's a kind of feedback and thanks and request. Thanks for the session especially. I'm a social worker on Rehabilitation Trust, and especially a mother of 1.5 years old kid. So, as sir mentioned the sodium intake, and we are also talking about this sugar intake. I did my checkups, ANC checkups, and my delivery was fully in government. I used PHC to take my checkups, and I delivered my baby in Madurai Rajaji hospital. So after that only I have learned so many things regarding this sodium intake, and that is through Instagrams, and there are so many lactation professionals who are making it as a trade to the public. So I want to have this this task in a SBCC strategy to educate the people. And I also did my internship in PHC also, 1 month PHC as a medical social worker in Kalikudi block in Madurai. So I seen that this health education is lagging in us. So I strongly believe that DPH can do that. I'm seeing this as a rich and poor struggle. Those who are going for medical private hospitals can get these educations, and those who are knowing these Instagrams and they are getting this education. But otherwise, the people at the root area are missing it. So I was so worried of this for a long day, and this session is a thought-provoking. And thank you so much for the session. I strongly believe that DPH can do this health education. Thank you, sir. Please include it in ANC checkups, please.
Thank you. I think this is a recommendation, and we'll end with that. Yeah. Yes, sir.
Thank you, madam. We are planning chromosomal based IPC. Don't worry.
Yes,
Actually, the stress is not due to work. It is due to burden. Because VHN is considered as a bullock.
Yes, yes.
And everybody puts work on the VHN or the medical officer. And any program, you say VHN can do this. VHN medical officer can do this. PHC can do this. There should be a global policy or at least a national policy that in government there should not be any downsizing of HR.
Absolutely.
It is not like Apollo. And people say, yeah, why you are not keeping a hospital like Apollo? Apollo, there are humpty number of people doing the cleaning work. Absolutely. But here, for giving one hospital worker, there is a policy coming in the name of finance that says, they say that we have to downsize. We don't have finance. But people like you should recommend, particularly people like Aarushi, can say that you create a new workforce. Yeah. Add at least, because even in newborn wards, for children who are newborn and they are in the NICU or SNCU, one nurse is looking after 50 children. How is it possible? And we are trying to compare with the private hospitals, corporate hospitals. And the other side, they say, don't have to recruit. So this is a paradox, which is going on throughout for the past 5 years.
Thank you, sir.
And the first and the foremost person who is affected is the VHN.
Absolutely. Thank you, sir. So we will close the panel with this, and thank you very much all panelists for this great sharing your thoughts and being. Yes, ma'am, want to make a last remark? Yes.
It's for the DPH, sir. Sir, regarding vaccination, now the Indian-based vaccination has come into use, in production and use. All these days, all others were all foreign. So now we have got our own vaccine. I think we should start. And
yeah, it is not yet in the market. No. It should come, yes.
And second is coming to the screening, sir. It should be more organized. It's now, as of now, opportunistic, HPV testing, organized. Yeah. Coming to the treatment part, only Tamil Nadu has got thermal ablation in all the PHCs.
Excellent.
And I think we have to do an effective use of it. So we need to be closely monitoring them. Yeah. Thank you, sir.
Thank you. Thank you very much. Thank you all. Thanks a lot.
That was a delightful discussion. Now I cordially invite Dr. P. Vadivelan, Directorate of Public Health and Preventive Medicine, Officer on Special Duty, to felicitate the Chair, Dr. Prabhdeep Kaur, for graciously moderating the panel discussion. I request sir to honor our panelist, Professor Dr. Ramani Rajendran. I request our OSD sir to present the memento to Dr. Ranjan Kumar Jha. Now sir will honor Dr. Aarushi Bhatnagar. I request sir to felicitate Dr. Jerard Maria Selvam. I request our OSD sir to felicitate Dr. K Krishnaraj. We will break for the lunch and kindly we request you to assemble in the hall by 2:45 p.m. We will continue with the session from Dr. Ganesh Kumar, Dr. Suresh Munasamy, Dr. Ranjan Joshi and Dr. Anand Kumar Paulraj post lunch. Thank you.